Good afternoon, everyone. Welcome to this broadcast. Thank you all for joining. As you all are entering into this virtual space and ready to soak in this knowledge that I have for you today, we'll be talking about. And as you all are coming in, first of all, I want to thank BlackDoctors.org for even holding this space for us to talk about this really important topic, especially during Black History Month. We'll be addressing mental health challenges among African Americans diagnosed with HIV, and I will be your presenter this afternoon. I'm Dr. Kendall Moody. I'm an assistant professor in the School of Social Work at Howard University. My background is in medical social work. I'm also an early investigator slash researcher for the Center for AIDS Research in Washington, D.C. So this topic is near and dear to my heart, and as I was, putting this all together, these are the objectives that I have for you all. And as I was putting this together, it sort of reminded me of a conversation I was having with one of my students at the Howard University, who works closely with patients with HIV. And through that conversation, uh, several themes emerged as I was asking him, so what are you seeing on the front lines as you're working with people diagnosed with HIV, most of whom are African American, which we'll talk about in this presentation, the disparity there. But, he mentioned a lot of themes emerged, and he mentioned constructs such as stigma and racism and culture and mental health, life was happening, and it was causing some issues there. So just through that conversation that I had with him, I put together this presentation thinking about the most important takeaways that I had for you all who are joining. Uh, it won't go in this order, but at the end of this presentation, I would like for you to take home just a deeper understanding of when we mention intersectionality among African Americans diagnosed with HIV, also exploring stigma and the role stigma and discrimination play and its impact on African Americans with HIV. And we're also going to look at some uh, interventions, some mental health interventions that can be tailored to meet the needs of African Americans with diagnosed with HIV. We're going to look at both the systemic and individual barriers that are present that cause some issues with African Americans gaining access to mental health resources. Also, have some resources that I want to share with you if you or someone diagnosed with HIV will need mental health intervention. And then also, we're going to explore some statistical data, some current data um, centering on HIV within the African American community. So that's the take home that I want you all to leave with as we uh, as we build, as we grow, as we talk about this important topic. I don't think it's talked about enough in our community. It's sort of taboo. Um, so uh, Leaving here today, understanding the role of stigma and how we can unintentionally perpetuate that cycle of stigma, and what we can do to improve. So that's the takeaway. And usually, I have these conversations where there's a group of people that I can interact with. So throughout this presentation, you may see some of these questions pop up. Um, but just think to yourself as we read this and as I ask you this question. Since 2008, newly diagnosed HIV cases in the United States has been trending. And just think about which direction do you feel that it's been trending here. And you see the correct answer up there already. Usually that's hidden before I ask you that. But if you said to yourself B, trending down, then you would be correct. Yes, we are seeing the new HIV cases trending downward since 2008. So this is good, and this all comes from uh, years of research, policies, education that we've been doing, focusing on HIV. You may say to yourself, well, it's not moving fast enough. We're still seeing tens of thousands of people diagnosed with HIV each year. And as you see here, this big dip here is uh, the year we don't talk about, 2020. The year. So you may see that dip there. So please interpret that with caution. Um, but it's been trending downward, and that's good. I want to highlight that. But I also want to highlight a disparity that we need to focus on, or be mindful of. So the next few slides that you see, um, it's meant to highlight an issue. Okay, it's not meant to pit one group against the other. That's not the goal of this. The goal is for us to understand a health disparity that's impacting the African American community. So as you see here, these are newly diagnosed HIV cases by race, and we're looking at the year 2020, 2005, excuse me, 2005 versus the year 2021. And we're seeing that in the year 2005, which represents this dark gray shaded area here, this bar, we're seeing close to almost 50% of all new cases are African American. And since then, we're seeing close to 40%. So uh, we're seeing a drop there, but we're still, as you can see, leading the pack among new HIV cases among African Americans. And now this comes despite African Americans representing only uh, 12 to 13% of the population. Yet we're still being diagnosed with HIV at a faster rate than any other race that's out there. Here's another slide that depicts this. And up to the left, you see that the current number of people living with HIV in 2021. I looked at the most recent data. This has gone up. It's now about 1.2 million people diagnosed with HIV. But it gives a little bit more of a breakdown into um, based on gender, sex, based off of race, based off age. And as you can see here, this number hasn't really changed much. When I looked at the most recent data, African Americans are still representing close to 40% of all new HIV cases here. So we are seeing that disparity, which most of which are male. Okay. Here's another map that sort of depicts this, and I'll interpret this because it can be a little bit challenging to understand here. Even I had to do a little bit more research on it. So this map shows the prevalence of HIV across the United States, and what the dark red means is that per 100,000 people, how many of those 100,000 people are diagnosed with HIV per 100,000 people. So the more people out of 100,000 per 100,000 that are diagnosed, you'll see this dark red here. Okay. So as I go through the next couple of slides, you'll see this start to change a bit. Okay. In comparison to Caucasian Americans, you see that you're not seeing that dark, deep red in most areas as we once were, as the previous slide, right? It changes so that the lighter yellowish that's not a high, as high a prevalency rate. And as we look at African Americans diagnosed with HIV, you're starting to see that really deep red in in these states here, showing that African Americans are diagnosed at a higher rate of HIV among all races. Okay, so again, we still have some work to do. We're seeing that decline happen, but there's still a lot of work that needs to be done involving education around HIV. Okay, so here's the goal. Here's what this is. We like to look at treatment and prevention in terms of the HIV care continuum here. So whenever there's a new diagnosis, right, we want to do our best to, one, increase testing, increase testing sites. But once there's a new diagnosis, we want to do our best to link them to care. That's our goal, is to link them to care. Once they're in care, we want to do our best to have them develop a treatment plan and adhere to that treatment plan, whether it's coming into your doctor's visits, taking antiretroviral medication, and maintaining that, right? Staying in care, being retained in care is our goal, so that they ultimately reach viral suppression. That's the goal, is viral suppression. Okay. Now, here's what's happening. Here's what's happening is that when people are linked to care, African Americans, excuse me, when African Americans are linked to care, they're falling out of care right around the time where they're receiving care. And our goal is to keep them in care. They're falling out right around here. They're not reaching viral suppression as at the same pace as other races. And here's what I mean: the portion of people who were virally suppressed in 2021. You see here that Black or African American people, only 61% of those who were diagnosed with HIV reached viral suppression. Okay. Um, so that's a problem. That's a disparity. Again, we represent only 12 to 13% of the population being diagnosed at a faster rate, but then also not reaching viral suppression at the same rate or occurrence as other races here. And it may beg the question as to why that is. Why are we seeing such a huge disparity here? There's tons of research that's out there that describes this and and highlights this, but I want to talk a little bit more about mental health, the implications of mental health. How does our mental health impact um, the patient's ability? How does the patient's mental health impact their ability to, one, be linked to care, but also reach viral suppression? What role does mental health play in that? Okay. And I want you to just think about this for a moment and sit with this for a moment. So imagine you're going to the doctor's office. Maybe you've had flu-like symptoms for a while, right? And you're going to the doctor's office, and the doctor comes in and tells you that you've been diagnosed with HIV. Think about all of the reactions that come from that. These are real reactions that patients go through. And what we see here, based on this study, where patients were asked about their initial reactions to being diagnosed with HIV. These are some of the things that they shared. We see fear, we see hopelessness, right, from the initial diagnosis. Some even have suicidal ideations. So we see here at the top where we talk about fear. This person talks about, in the beginning, I worried that my children were still young. So this person had children. Um, I was afraid I would die, leaving them to their fate. So it got me thinking a lot. Okay. Suicidal ideations. This person talks about, in the beginning, when I was told, truly I went crazy. So I made up my mind that if so, then I would call my children and have this another person with children and share the little I have for them, because I was out of time and wanted to die. So these are real feelings. These are real reactions that we have to talk about, that I don't feel as though we're talking about enough in our community here, the African American community. These are some of the common psychological disorders that you'll see as it relates to HIV. And I apologize, this slide if it's coming in a little distorted, but I'll describe it for you if it is distorted. But we're seeing those who with depression diagnosed, anywhere from 12% to 66% of African Americans diagnosed with HIV. Anxiety, we're seeing anywhere from 6 to 23%, but between the ages of 9 and 18, so that younger population, anywhere up to 68% of those individuals are diagnosed with some form of anxiety disorder. And then PTSD. Most often you hear PTSD associated with like war military veterans, but yes, you can be diagnosed with PTSD as a form of medical trauma. So that initial diagnosis may cause people to, if you encounter a hospital, you may have some of those same reactions just walking into the hospital, as if you had just received that diagnosis, that initial diagnosis. Also, I want to highlight the difference between a depressive disorder and having depressive symptoms, anxiety disorder and having anxiety symptoms, because you can have symptoms of depression and anxiety without having a true disorder, right? So if you're feeling as though your patients may feel sadness, that's a depressive symptom. But if they're feeling sadness, having other uh, situations or issues such as a loss of interest in doing things that they typically like to do, fatigue, over an extended period of time, then it can morph into a true psychological disorder. Okay. So I wanted to highlight that as well, so you understood the difference between being diagnosed with a true disorder and having symptoms of that disorder. Okay. Also, uh, these psychological disorders and symptoms are not unilateral. They oftentimes, and they're really savvy, right? So you can have depression, but it or depressive symptoms, and as you're going about your day, you've been doing just fine. And as soon as you're engaging in some form of activity that you like to do, whether it's going to the gym or if you're spending time with family and friends, right? Depression will sort of seep into your mind and uh, cause you to not really enjoy the activity that you once enjoyed. It may, well, why are you doing this? Well, why are you spending time with family and friends? Start to question. These are some of the things patients have shared. And from there comes the anxiety. From there comes the hopelessness and the self harm and the suicidal ideations there. So, later on, we'll talk about some strategies to try to manage some of these thoughts and feelings. But this is what we're seeing. This is what we're seeing among this population. So what do we do? What do we do now that we know that patients with HIV also are at risk of experiencing some form of mental health issue? There are barriers there. There are barriers systemically. There are barriers within our community that prevent or make it hard for African Americans to engage with mental health professionals. So again, if we were, in the space where we could interact with one another, I would ask this question or pose this as a statement and ask what you all thought about this. But you all may have heard this before. I'm sure you have. Black people don't go to therapy, right? And I would ask, what do you think about that? What comes to mind? Have you heard this before? Have you heard it within your family, friends? What have they said about this? And yes, historically, we African Americans have treated therapy as, well, why go talk to a stranger about your problems? We uh, tended to lean more towards like the church, oh, well, go pray it away and talk to your pastor. Um, so there's been a little bit of a mistrust with the therapeutic system, rightfully so, rightfully so. I think things are changing a bit now. Things are changing. The landscape is changing as far as our narrative about going to therapy. My students now are talking so openly about having a therapist. Right, we're seeing it in pop culture where celebrities are being open about having depression, anxiety, and talking about going to therapy. So I think the landscape is changing. So I'll say, in regards to this statement, yes and no. Yes and no. Yes, we've historically not engaged um, in the mental health system, but I think that's changing now. This slide depicts, the prevalence of engagement among the two different races, Black and white, in 2022. So we saw around 39% of African Americans that needed mental health. Those are the ones who were diagnosed with some form of mental health disorder. Only 39% received mental health treatment, as opposed to 52% of white Americans receive that. You may say, well, that's not much of a difference there. Well, when you start talking about tens of millions of people, then yeah, it is a huge difference. So, um, again, it goes into, why is that? Why are we not seeing African Americans engaging in the mental health system? Again, we talked about historically, why that was, but there are a few barriers there that also are present that we need to talk about. A couple of those being stigma and discrimination, right? So I want to describe those. The stigma, we talk about think about stigma as attitudes and beliefs. So negative attitudes and beliefs that people have towards a particular group and label them as socially undesirable, right? That's stigma. So it's more about attitudes and beliefs. Now, discrimination is the behavior stemming from those negative attitudes and beliefs. And we're going to do a deeper dive into that here shortly. But it takes on this idea that it's us versus them. Them over there, they do this, they're undesirable, they're not a part of us. And so there's a separation there, right? And that creates this environment of discrimination and racism. So, and we're going to do a deeper dive into that here shortly. Um, 80%, 80% of Black Americans say they are very concerned about stigma, and that's the reason why they are discouraged from seeking mental health services, all due to stigma. And we're going to talk about ways that we can tailor our mental health to meet the needs of African Americans. But 80% say, based off stigma, is the reason why they don't engage with the mental health system. Okay. And I mean, being stigmatized being stigmatized can lead to these issues: social isolation, poor medical adherence, depression. We talked about social isolation before, and I want to highlight that because that's so important. That's a key factor here. Whenever I'm working with patients, I'm always curious about their relationships with their families, their peer groups. That is a huge indicator of how well they'll do in treatment, and it's also an indicator of how severe some of their mental health concerns are. Um, we're seeing that people who have a community around them do better, a family, peer groups around them do better, and as they start to unplug from that community, that family, that social group, that peer group, then we're seeing that they have worse outcomes. So this is one that I really want to highlight as a huge indicator and outcome of stigma and how powerful stigma and discrimination can be. Okay. As it relates to HIV specifically, these are some of the things that we're seeing, and we're seeing them in all different facets and systems that people with HIV have to engage with, right? So, uh, oftentimes we hear people blaming the person for their infection, right? Oh, it's they did something to cause this, right? So that's a stigma. That is a stigma. Discrimination, refusing to care for a person based off of their disease status. That's discrimination and racism. Okay. We have to be mindful of that because this is happening. This is happening. I want to highlight this last one under discrimination here as well. Referring to patients as HIVers or positives. Don't, if that's happening, please try to be mindful not to do that. We like to lead with person centered uh, care. Calling someone HIV or associates them with their disease, and we try to separate the two. They're a person first. They're a person first, right? And that's some of the things that we try to unwind in therapy as well. So just being mindful of that and how that can perpetuate this cycle of discrimination and stigma here. So here's a person who engaged with the healthcare system, and there's a lot of research on this. I only highlighted one quote here, but this person talks about their engagement with the healthcare system and how they feel discriminated against based off that. And they say here, at the hospital when we come, everybody knows who we are. Infected people want as few people to know about their situation as possible. With other diseases like hepatitis, the patients may die sooner, but aren't as discriminated against. This disease is a repellent. Therefore, at the hospital, there is a room reserved for patients with HIV/AIDS disease, right? So imagine you're going for care and you're experiencing this, that us versus them, oh, put them over there, that fear of engagement, right? What is the likelihood that you're going to want to engage in that system again, right? It's low. That impacts care, that impacts our outcomes that we're looking for, right? And these are system related issues. Okay. So this highlights that. All right. Also, costs. The cost of mental health treatment. I think we spent hundreds of millions of dollars last year on mental health care in the United States. Right. Um, U.S. adults reported that they went their mental health went untreated, 42% said because they couldn't afford it. They couldn't afford it, right? This again, it's a systemic issue, and we're trying to hurdle this barrier by Medicaid expansion, having people who are uninsured obtain insurance, but even then, there are some issues with it. So again, we're trying to do our best to manage this, but cost is also another barrier here. We're also seeing limited providers in these high need areas. So look at this stat here, and just in 2022, 40% of the population were living in an area where there was a mental health shortage. Okay. I'll highlight Washington, D.C. for a moment here. So here in Washington, D.C., if you're familiar with the D.C. area, you know that we're broken up into different wards. So Ward 1 through 8 in Washington, D.C., with most of the Black population being here on the bottom, the dark blue shaded area, Ward 7 and 8. And over here at the top, Ward 5 as well, but mostly Ward 7 and 8 is where you'll see the higher concentration of African Americans. So, I went on to Google and I typed in, you know, looked at the map and typed in mental health clinics in Washington, D.C., and I wanted to see what popped up. And this is what popped up here. So I'll try to draw the line for Washington, D.C. here. So Washington, D.C., of course, sits Maryland sits next to us, and Virginia sits next to us. And there's I don't know if you can see this faint line here, this dotted line that I'm trying to trace with my mouse here around the Capitol Heights area all the way down. Um, Ward 7 and 8 is separated by this Anacostia River, right? So it's sort of detached from some of the other wards there. So this is Ward 7 and 8 here. You'll see not as many red pins pop up, right, in this area here. Most of them are centered in this middle part of DC here, right? So, and even still, I don't, I've typed in mental health clinic. I'm not even sure how much mental health is provided at some of the places that popped up, but we're seeing a resource deprivation here, whereas this is an area where that is much needed. Mental health is much needed in these areas, but they're just not there. They're just not there. So there is some information I'm going to share with you all about how this is starting to change a bit. But as it currently stands, this is a problem. This is an issue here in Washington, D.C. And I'm curious to know if it's happening in areas where you all reside. And then also there's mistrust. I mentioned mistrust last time earlier in this presentation as to why we're not engaging in the mental health system. But mistrust can lead to more ER visits, meaning if you're not engaging in the mental health system, you're not managing your own chronic illness, then you're likely to have more visits to the ER, least likely to be taking your medication because again, depression, anxiety, PTSD, these things are all really savvy. And if we're not being mindful of how it is impacting us in our mind, then our hope just goes away, right? And then you're not likely to do the things that you should do to keep yourself healthy, right? So we're seeing that all related to mistrust. Also, our providers, mental health providers, and I know I'm African American social worker. There's not a lot of me walking around engaging or within the mental health system here. So we're seeing that most of the mental health providers are white. They're white. So, and we know through research that when African Americans are interested in mental health and they're met with a white provider or a provider outside of the race or culture, then there is a little bit of there's a little bit of a guard that comes up. There's a little bit of a guard. So, and throughout this next part of the presentation, I want to talk about how we can tailor some of our approaches to meet the needs of African Americans so that that guard will start to come down, right? So, and that's what I want to talk about. I want to talk about culturally intelligent mental health interventions. Also, cultural competence is another way to describe this. What is culture? When you go to Google and you type in images culture, often the images that you see are related to race and ethnicity, right? So, but culture is so much more than that. It's so much more deep than that. Age, socioeconomic status, all the things you see here can define someone's culture, right? As we think about African Americans, one can be at a bit of a disadvantage if you assume that African Americans, you know all about the African American culture, because we're not a monolithic group. It's not a cookie cutter group. You know, you can encounter an African American group in the southeast region of the United States and have a very different culture, viewpoint, traditions, and African Americans that grew up in the northwest portion of the United States. So, you know, we're not a monolithic group. We come from different nationalities, ethnicities. So it's important for us to not pigeonhole ourselves into thinking that, oh, yeah, okay, I worked with African Americans before. I know exactly how to take this on. Now, there are some similarities across uh, the African American culture, and I'll talk about that. But be mindful that we're not a monolithic group here. Cultural intelligence, right? I do something with my students, and because the first part of having cultural intelligence is awareness. You have to be aware of your own bias towards a particular group if you're going to work with that population. Okay, so I do this activity with them, and I talk about, and I flash pictures on the screen, and sometimes the pictures will have a little bit of a description next to it. And I just ask them to ask themselves certain questions as they see these images. Is this person uh, truthful? Is this person? Do you trust this person? Would you work with this person? You're just asking yourself. They're asking themselves these questions as they see these images pop up, and it's almost as if you have to check in with yourself and say, oh, okay, I didn't realize I had this bias towards this particular group, right? And if they don't have that level of awareness, as soon as they meet someone from that group, there's a higher likelihood that they're going to carry that bias into how they treat them and unintentionally or intentionally discriminate against that person, which is what we don't want. That's what we don't want. So having cultural intelligence is really important. Intersectionality. I mentioned this earlier, but I really want to define this. So this is when uh, different systems, two or more systems or constructs, social constructs, interact with one another, and then they produce a potentially discriminatory system that evolves from that. All right. So I have an example that I want to show as to what that is. So, Aaron, imagine this case vignette here, and these are the different systems that are interacting with one another. And I want you all to think about the likelihood of this person uh, ex- experiencing any type of stigma discrimination. So, Erin is a 34-year-old transgender African American woman who was recently diagnosed with HIV. After her diagnosis, Erin started experiencing depressive symptoms, self isolation, crying spells, some of these intrusive thoughts. And Erin is also has limited income. She's fearful that the cost of mental health treatment will impact her employment. Okay. So just from that case vignette, this story, we see several systems emerge here, and the intersection of all of these systems create another system of how someone can be discriminated against. So we have gender identity, and Erin is a transgender. She's African American. She's HIV positive, and she also has some depressive symptoms. Now, each of these carry their own stigma. Now, imagine them interacting and lump together. Imagine that. So now she has to go out and interact in a world, um, knowing that there's stigma and discrimination that she has to face. So how will she do that? It could be really scary. It could be really scary. So this is an example of intersectionality. Okay. Here's another one of those questions that I would ask you all if we were in person. Um, and the answer here is D, two. Over the past 25 years, there's only been two research studies that surveyed clinicians about their conceptualization of cultural sensitivity. So there needs to be more work done in this area as well. Okay. So in this part, I'm going to go through a series of interventions. I'm going to talk about if uh, if you're a mental health practitioner, some tips and tricks working with African Americans, so tailoring some of the approaches to African Americans who are engaged in the mental health system. If you're a family or friends of someone with HIV, not in the mental health world, I also have some strategies for you as well. So don't get lost into some of the things I'm about to talk about. Um, and then I'll talk about some of the policies that need to change, and that'll lead us to the last half of this presentation here. So there was a study that was done in 2012, and the researchers of this study wanted to know what was important for African Americans who were already engaged in the mental health system. What was important for them? Um, what do they want to receive from their mental health provider? Okay, and these are some of the things that they shared. They reported wanting to feel comfortable with the provider. They wanted to feel safe to disclose some personal information. Remember, it takes a lot of strength to be able to talk to a stranger about some of the most darkest, deepest secrets that you have, right? So they want to feel safe. We want to feel safe. I'll include myself. As an African American, yes, if I were to go to therapy, I want to feel like I know that my provider, I can trust my provider, that my provider will listen to me and respect me as a person before I even tell them what brought me to see them. Right. So I want you all to remember this as we go through this and some of the things that we would like to see as we're engaging in the mental health system here. Also, before we get to that, I wanted to highlight I didn't know quite where to put it in this presentation, but at Howard University, we have in the School of Social Work, we operate from the Black perspective. So these are principles based off of Black African culture in the African diaspora that we use when we're thinking about working with individuals, working with groups, working with systems, working with policies. These are the principles that we use, and they stem from African culture. They stem from the African diaspora, right? So we use this at Howard University as a way to work with individuals, families, groups, and if you get into policy work. So this is for providers. If you're a mental health provider and tailoring some of the work towards African Americans, it's really important. It may seem like duh, yes, I know this, but I tell my students this is probably the most critical part of the therapeutic process. It's simply introducing yourself, right? Telling the person who you are. Now, you may assume that if you work in, let's say, a hospital setting, you may assume that the patients may see you and know who you are because you walk around the clinic or the unit or wherever you are and they know who you are. But no, introduce yourself. Give them your name, how many years of experience you have, shake their hand, be personal. Remember the things that African Americans value as far as the relationship that they have with their provider. You want to discuss and be open with them as far as the plan for mental health treatment, but also remember confidentiality. There's discussion now about the importance of disclosure, right? Disclosing your HIV status. Some feel as though that's their own personal business. Some feel as though that disclosure will help curb some of the stigma. Respect that person's decision to not disclose. So confidentiality is really important, and discussing confidentiality is really important as we tailor some of these interventions towards African Americans. If you're working in a clinic, if you're a mental health provider, I do recommend these mental health screening tools. Depression, for example, PHQ-9, the patient health questionnaire. You can use the PHQ-2, which is 2 questions, and if they screen positive, then you can use the PHQ-9. The goal is for you, once they complete it, there should be a mental health professional that kind of comes back up to the top and asks them to elaborate on some of those answers, because these will caution you do have a high rate of false positives. Meaning, if some of these questions, if they're not followed up by an interview, then it may not be directly related to depression. It could be related to other social constructs that you can't really assess for unless you ask the question. So I do recommend incorporating these into your clinic. build the therapeutic relationship. Build the therapeutic relationship. And what this looks like is speaking with the person, speaking with your patient about their traditions, their culture, things that they like to do that makes them who they are outside of their HIV status, outside of what brought them in to see you. So putting down that clipboard or whatever's in your hands and focusing on getting to know the person that's in front of you. As I said before, African Americans are not a monolithic group. If you work with one, you work with the next one, they can be very different. So understanding that person's culture through them is what's important. And how you do that is you're focusing on that relationship that you have with them. I often talk to my students about the difference between rapport and relationships, therapeutic relationships. And we talk about, I even asked them to not use that word rapport. Rapport can be kind of surfacey. It's like, how's the weather outside? Oh, it's nasty, that sort of thing. But therapeutic relationship is much deeper. It's an I get you and you get me as the provider. Okay. It's that shared understanding between you and the patient. African Americans value the therapeutic relationship. You can have all of the experience and all the interventions as a mental health provider, but if you don't have that therapeutic relationship with African Americans as they're engaged in the mental health process, it's not going to work out well. The likelihood that they'll achieve the goals outlined in the treatment plan are much lower. So focusing on that therapeutic relationship is key. Okay. I also recommend cognitive behavioral therapy as a treatment option. Cognitive behavioral therapy has been well researched. It's been used in all different types of groups, including those who are diagnosed with a chronic illness. And what it is, it helps the person understand how their thoughts are now connected to their feelings, which are connected to certain behaviors. To describe this even more, I'll give an example. So when I fly in an airplane and we hit turbulence, in my mind, and I know this is irrational, but in my mind, I'm thinking the plane is going down. I'm thinking at some point this plane is just going to fall out of the sky. Of course, that's irrational. Planes will just fall out of the sky, but that's what turbulence does. So based off that thought, I start to have these really intense feelings of anxiety, right? And then I start my behavior. I start, maybe gripping the seat next to me. We're going to go through some things a little bit later on in this presentation to try to manage some of this, but usually I go into my deep breathing and I try to have rational thought come back and say, you know what? This plane is not going to just fall out of the sky. When have you ever seen that happen? So those are irrational thoughts that I had that I try to manage. And it's all based on this cognitive behavioral process here. All right. So we're going to do a deeper dive into what this looks like for those with HIV. Again, I apologize if this comes in a little distorted here, but I'll describe it. So, based off of stigma, based off discrimination, based off of culture, disease status, individuals with HIV have thoughts that pop into their mind based off these experiences. Those in turn will elicit really, really intense feelings. We talked about the initial reaction to having that diagnosis and what feelings emerged. And then there's behaviors that come from that. Either they have poor adherence to their treatment plan, avoid the hospital, focus on other things, and denial, distraction. And this cycle is perpetuated, right? So based on some of these, and this is another example here, based on some of these experiences with stigma and discrimination, they may start to tell themselves, based on my disease status, I'm going to be alone. I'm unlovable. I'm dumb. How did I let this happen? These things start to creep into their mind, and they really believe this to the core, right? And then that begins the cycle of, you know, the thoughts pop into their head. This is difficult. I don't want to do this anymore. Depressive symptoms, that self-isolation that I talked about, maybe loss of interest in doing things and then that leads to um, not going into the hospital, engaging in the hospital system, seeking out treatment, staying active on their treatment, leading to poor outcomes here. So what we try to do is we try to combat these doubt labels that they have, right? We try to one understand what their doubt labels are, but then try to unravel this vicious cycle through a lot of different avenues here. And I'll go through this pretty swiftly for the sake of time. But through this process, we want to educate. We want to educate the client about how CBT works. We want to educate them about their HIV treatment. So you do, as a mental health provider, need to know a little bit about HIV, the treatment process, and what that looks like. Okay? You want to understand the challenges and the misconceptions about HIV, so you can educate the client about that. You want them to develop coping strategies to be able to manage some of those really intense feelings. Like I said, I use that deep breathing, that diaphragmatic breathing. And once we do that, then some of that rational thought comes back. Okay. If you have a client who has anxiety, for example, you want them to develop a toolkit to manage that anxiety. And some of those are what we call mindfulness strategies. So um, I have some patients who struggle with social anxiety or being outside, or whenever they're going into the hospital, that's when an anxiety hits. So the penny in the pocket is one strategy. Is just carrying something in their hand, whether it's a penny, whether it's a paper clip. Sometimes they have like little fidget spinners. Just playing with something in their hand helps to take some of that their attention away from what they're thinking, alleviating some of those really intense feelings and focusing on what's in their hand. So that's one strategy that you can use. There are others, but um, I won't do a deep dive just for the sake of time here. We want to focus on cognitive restructuring and looking at ways in which we can address stigma through. Okay, so if you feel as though you're being stigmatized against and you have to interact with the hospital, what are some things that we can do that aren't avoiding the hospital, but as you're engaging in the hospital, what can we do to help alleviate some of that discrimination or minimize some of the discrimination? And what you can do is do some role play, role rehearsal with your patient to help them think about ways they can respond to it before they have to go to their doctor's appointment, before they have to engage in the healthcare system, before they have to go to church, before they have to talk to their friends about their disease status. You can rehearse that with them. Communication, sex, sexual health, talking about relationships. Now, some people feel as though their doubt labels, now I'm unlovable. I won't be in a relationship. I can't get in a relationship now because of my disease status. And we know that's not true. We know that's not true. So talking with them and exploring their sexuality, creating a safe space for them to do so. Again, building that relationship with patients and clients is important, because they're not going to be so comfortable to talk about some of these really deep things that are affecting them if you don't have that therapeutic relationship with your clients, specifically African American clients. You want to collaborate, do this with your patient. You want to set goals for them, goals that will help motivate them to stay in care. That's the goal. Okay. Turn them into problem solvers. So if they're faced with a challenging situation, which will happen, happens to everyone. So instead of uh, thinking about the problem as being an issue that they can't handle, focus on problem solving strategies to help them hurdle some of these thoughts that they have. We want to identify triggers. So what do they feel as though will be a trigger that keeps them out of engaging in the healthcare system? All right. You want to identify those and come up with a plan so that those triggers don't impact them. And then you want to develop an adherence plan, a plan that will help them stay engaged in the mental health system. And involve the family as much as you can. And this is one that I said when I was talking about we're not a monolithic group. Across African Americans, we tend to value family, even not just the nuclear family, even extended family. Um, People that as you grew up, you didn't realize weren't your aunt or uncle. You realize they were just part of your family. They knew your parents growing up, right? So we value family. So include family as much as you can into your treatment process. There are certain clinics that have family-centered services, and they have family day. So they invite the families, mostly in pediatric and adolescent clinics. They invite the family to come in so that they can learn about HIV. They can talk about adherence. They can dispel any myths that they may have heard about HIV. And in that engagement, we see positive outcomes with that population. So if you're a provider, a medical provider, then having family centered services like a family clinic day is maybe valuable to add. The use of support groups. Uh, it's n- it, the support groups are invaluable. They're really valuable. It. And here's a quote that speaks to that. And this person says, I didn't mean to highlight the whole thing. It's really just the first couple of sentences there. So I'll just read the first couple of sentences. And this person says, I like groups because there's always somebody in the group who is at least one or two acknowledges their depression. And the treatment can encourage other people that it's okay, right? So having people who are going through some of the same feelings that have some of the same feelings that you have can normalize it a bit, right? And put yourself at ease for a moment, right? And that's good. That's the value of these support groups. So engaging support groups. The use of telehealth, which has been growing since COVID-19, it increases access to care. Um, Telehealth among African American groups, we want to make sure that we're still trying to um, elicit that therapeutic relationship. Sometimes it could be a bit difficult through the computer because some things are missed. But as best you can, still focus on that. But telehealth is also can also be a valuable tool to hurdle some of these barriers. All right, so here's the portion that if you're a family or a family member or a friend of someone with HIV, some of the things that you can do to help, right? So the first thing is noticing these changes in behavior. If you know that your friend or your family member is usually upbeat, jovial, and then you notice that they're a little bit more silent and more just to themselves, you see them more often than anyone else in the medical system. You see them throughout your maybe multiple times a day, maybe multiple times a week. Notice that change of behavior. Notice it. All right. And if you notice that things are changing, create create a space for them to talk openly about it. Don't distance yourself. Don't distance yourself. We see that sometimes where family members will pull away. They don't know what to say. They don't know how to speak normally. Speak normally. Don't pull away. They notice that. They notice when people start to distance themselves from them. And that unintentionally perpetuates this cycle of stigma and discrimination. Okay. So at during those times you want to lean in, not lean away. Okay. Attend appointments as much as you can. Clinics, they welcome people to come and support the patient that they're there to see. So as best you can, support your friend and your family members by attending these appointments. Okay. All right. And as we get to the tail end of this, we have to focus on policies because we can do all these really great things, tailoring our mental health towards African Americans, being conscious of stigma and discrimination. But as we train new medical providers, as we train new mental health providers, and they're not educated on cultural competence, they're not educated on how to engage in the African American community, then they're going to intentionally or unintentionally perpetuate the cycle of stigma. Right. So we have to have policies in place that will educate future practitioners, that will educate future doctors on stigma discrimination so that when they get into the workforce, they know how to engage African Americans in practice. We have to develop comprehensive care models so when patients enter into or they're seen by a professional, they're met with a psychologist, they're met with a nurse or a health educator worker, they legal counsel. You'd be surprised how many people are still losing their jobs based off their disease status, how they're not getting the right medical insurance or denied disability and other claims because of their disease status, and having legal counsel can really help that. We need to increase our funding for clinics in these high need areas. And I think, as I mentioned earlier, I want to highlight some of the things that Washington, D.C. is doing. But we also want to increase our partnership with community organizations. So if you're operating in a clinic and you have access to community partners, collaborating with them would be really important as we engage the African American community. There's light ahead. There is light ahead of this tunnel. I know I went through a lot of the daunting stats and things about HIV. But as I mentioned before, there is a cultural shift. I think that we're talking about HIV a little bit more in the African American community. We're talking about mental health a little bit more. I'm sorry, that's what I meant to say. We're talking about mental health a little bit more in the African American community. We still need to talk about HIV. a little bit more and dispel some of the myths. Um, there's new initiatives that are focusing on HIV. The NIH has some interest in in looking at how we can eradicate the disparity among African Americans. And then, as a nation, we are doing a great job of getting. We can do better. We can do better, but we're seeing that more and more people now have access to health insurance. And that's really good. I think we're heading in the right direction with that, with the expansion of Medicaid, with the um, people call Obamacare, Affordable Care Act. I think we're having more access to insurance, which gives us access to mental health services. Now we still have to tackle the issue of cost. That's still an issue, and we still have to tackle other issues that we talked about. But I still think there's light at the end of the tunnel here. And here's what I was saying, as far as like we're heading in the right direction, at least in Washington, D.C. As I mentioned before, Ward 7 and 8, those are the wards that really don't have, uh, there's a resource deprivation area for mental health. So there's a new hospital coming in Washington, D.C. in Ward 8, and I think it's supposed to be fully up and running next year, or maybe at the end of this year. But this is good. This is good information, and I think this is a step in the right direction to try to manage some of the mental health issues that we're seeing, specifically in those wards where, as you saw in that graphic, that map that I had up, it just we really didn't see a lot of mental health clinics pop up. So I think that's good and step in the right direction. So in closing, as we end this, I feel like I spit. I feel like I sort of speed talked about this whole thing, but there was so much I wanted to get in within this hour. We're seeing that African Americans diagnosed with HIV are not staying in care, and part of the issue is mental health. Right? They just have a life going on where it's their own care becomes less of a priority because they have so much other things going on. There's also some barriers that are there: stigma, discrimination, cost, lack of cultural intelligence among providers. So we have to do better in that area. And then, as I said before, I think the landscape is changing. I think we're talking about mental health a little bit more among the African American community, which is a step in the right direction. Okay. Hopefully, so if you have a way that you can take a picture of this slide, if you know someone who needs therapy, these are some of the websites that you can visit that will that focuses on African Americans, Black girls, Black men, and that's more like a resource where they can point you in the right direction as to where you can find therapists that are within our community. Okay, so if you can just take a quick snapshot of this before I go to the next slide. Thank you, thank you, thank you. I want to end this with a thank you to everyone who joined, specifically patients who are fighting HIV and AIDS daily, their families that are in the fight as well. Thank you to healthcare professionals. Thank you to community partners, researchers. We still need more researchers to do research in this field. But thank you all for joining and listening to me sort of speed talk throughout this presentation. Hopefully, you took away some valuable knowledge based off the information I shared. Here's the survey. Please, please, please complete the survey. If the QR code is up, if you just hold your camera up to the QR code, then a link will pop up. Click that link and complete the survey. If you want to talk more and build more about this, discuss more about this topic, I have provided my email address here, so you can email me and we can talk more about this topic. I feel like I can talk about it all day just because it's something that I'm really interested in, but I know that's just me. But if you share this love for this topic, I would love to chat with you more. So thank you all for joining. Thank you, family and friends, colleagues that joined. I appreciate your support. And again, if you want to reach out, there's my email address. But otherwise, please enjoy the rest of your afternoon. And thank you for joining.